Thank you for the opportunity to present our work. This is in no way another controversial paper, I don't think. These are our disclosures. As we heard in the last presentation, despite having emerged as the gold standard treatment for gastroesophageal reflux disease, the laparoscopic fundoplication can be associated with a 20 to a 30% failure rate, depending on how we define failure, of course. In most of these patients, we can manage medically, but 3 to 6% will require this revision operation that we just heard about. We do know that with the increasing number of these presentations that have been occurring, there are more and more people representing with persistent symptoms, and surgeons are often faced now with what do we do with the patient who has the third or fourth time presentation after their second or third failed anti-reflux operation. In this paper, we've coined a new term. We're going to call these super redos. Our purpose of our paper was to specifically address how are these patients doing who are undergoing super redo anti-reflux operations, but really examine their outcomes through the patient lens and assess their patient-reported outcomes in terms of functional quality of life. So this was our study design. I apologize for the screen here. We identified patients who were undergoing super redo anti-reflux surgery during an 18-year study period. And again, the way that we define super redos are people who are having third time or more gastroesophageal junction reoperation specifically for reflux. And all patients in this study were evaluated in a co-surgeon model by a general and a thoracic surgeon who are both the senior authors on this presentation. The patients were approached through a recruitment letter, and if they were consenting to participate, I interviewed them over the phone and administered 2 quality of life instruments, the SF-36 to address their general quality of life, and then the GERD health-related quality of life instrument to address their reflux-specific quality of life. Now, over this 18-year time period, we didn't have these instruments administered to these patients preoperatively for a pre-post analysis. So the way that we benchmarked our outcomes were by comparing these to population norms or those norms available in the literature. So on the left-hand side of the screen, on your screen left, shows our average annual case volume at our institution. And through the study period, this was approximately 63 cases per year. I'll walk you through the consort diagram given the screen, but we identified 1,500 patients who had undergone benign esophageal disease surgery during this time period, and 1,100 of those patients before reflux operation. Ultimately, 241 of those 241, 19 represented a redo operation or a super redo. Unfortunately, one patient did refuse to participate in the study, and so on the subsequent slides, you'll see our total sample size is 18, and then of those 18, 10 patients participated in the telephone interview for evaluation of quality of life. The makeup of these patients is shown here, average age being about 50. As we heard in the last presentation, consistent with this disease, there's a female predominance. The average BMI was 27. 13 patients had undergone 2 prior operations, and 5 of those 18 patients had undergone 3 or more prior operations, and their most predominant preoperative symptom was reflux. Operatively, 16 of the 18 patients began the operation with an open incision, 14 of which had a thoracolaparotomy. The most common mechanisms of failure that we identified, again consistent with what has been reported previously, is mediastinal herniation of some type or scarring and stricture at the gastroesophageal junction. You can see, given our small sample size, that the types of repair in the single digits, but all patients had a takedown of the prior fundoplication, an evaluation of the GE junction anatomy, and either a partial or complete fundoplication, and 4 patients did require an esophagogastrectomy. It's just to note that the next couple of slides report the outcomes at a median follow-up of 6 years, but that range is from 3 to 13 years, depending on the patient. There were 0 perioperative deaths, and 72% of our cohort were free of any complications during recovery. And the most common complications did indeed occur among those group that had the thoracoabdominal incision, and those were postoperative pneumonia and a wound infection. But as we said in the beginning of this talk, the main purpose of this was to evaluate outcomes from the patient perspective. And so shown here are the results of the general quality of life instrument that I administered to these patients over the phone. And in general, the SF-36 scores are provided in 8 health domains, with a score of 100 being the best score, the best quality of life. And you can see among our study sample, those 10 patients who were able to be contacted, their quality of life scores are shown for each domain. And then the population norms in the United States of America are shown right next to this. And the bottom line is that in no domain were the study population's quality of life scores lower than the US population norms. And in fact, in 4 out of the 8 health domains, they were significantly higher. But what about the disease-specific quality of life? So shown here are the results of the GERD HRQL instrument, and the majority of patients reported the resolution of their presenting symptom. Also provided by this instrument is an overall GERD score, and the mean score in this cohort was 11.3, but what exactly does that mean? So the modified GERD score is from 0 to 45, and 45 is the most disabling symptom that a person can present with. And while there aren't as many normative data available to compare GERD HRQL across different populations, we know that after first-time redo lap Nissens, for instance, the mean score is 14, and this score was not statistically significantly better. So in summary, what we found at a 6-year follow-up among these patients undergoing super redos is that the majority who did undergo surgery from an open incision had few perioperative complications and durable improvements in quality of life as measured by self-reported patient-reported outcomes. The first thing that we did when we contextualized these results is recognize that we are not the first, and certainly we will not be the last to try and study this complicated problem. Shown here on the slide are 5 landmark papers, and this slide is certainly not comprehensive, but these studies were particularly unique because they both included patients who were undergoing redo operations, and one of the primary endpoints was a patient-reported outcome. And what we can see is since Dr. Little's first report of these multiple revision surgeries in 1986, several other experienced centers have reported durable improvements in quality of life 1 to 3.5 years after the index operation. Our data add to these studies by contributing uniquely another cohort that predominantly underwent surgery through an open incision, and also at a relatively long-term follow-up of 6 years. To wrap this up, there are several lessons that we learned from reviewing this experience, and as with any operation, careful patient selection is critical to achieving a long-term result. But there are also several benefits that the 2 surgeons who sponsored this work realized in approaching these patients together, is that each separately evaluated the patient and their prior operations. They both felt that it increased confidence in the operating room when operating in a co-surgeon model and allowed to better facilitating of any intraoperative events. And then a lot of these outcomes, of course, go beyond the surgery and surgery clinics, but also have to do with the standardized protocols that have been developed with our GI and anesthesia colleagues. So in conclusion, we found that in this small study that patients undergoing a super redo anti-reflux operation, again, predominantly through an open incision, had durable improvements in their self-reported quality of life. Thank you again for the opportunity. I'd be more than happy to take any questions.